and looking at endpoints of death, heart failure, or hospitalization in two hospitals in the same town, you could see that there was a significant drop in those endpoints when you paced in one hospital almost all the time using his bundle leads, and the other hospital using the traditional right ventricular apical lead. You could see that if you follow those patients long enough, you will see that there is a significant reduction in those endpoints of heart failure, hospitalization, death, and or need for upgrade to a biventricular device. So his lead is truly, has become, a very, very nice target for pacing in general. So there's two big indications for pacing. One is the AV block patients and the sinus syndrome pacing. And in the last 5 years, the left bundle lead has become the default pacing lead. The his lead, the 3830 lead has become the default lead to use for pacing in any indication, even if it's just sick sinus syndrome. And the reason is there are patients who have conduction system disease that will progress to having more AV block. And basically, if you're going to put a lead for somebody for the next 10, 20, 30 years, then you might as well give them a very physiological pacing lead. For heart block, similarly, we have used that as a default. But the other indication has become also trying to correct heart failure. So, the thought was, why don't we look at having this as a therapy for heart failure in lieu or in addition to left ventricular pacing using a coronary sinus lead. So let's talk a little bit about why did we move down to left bundle pacing. Left bundle pacing actually was introduced by a Chinese group, and this was about maybe 3-4 years ago, where they decided that, hey, maybe we can capture the left bundle itself as opposed to just leaving it at the his lead. And the reason to look for alternatives became apparent on follow-up of many of the true his lead patients that ended up with either capture loss or increased thresholds or lead instability, and that basically had forced us not to rely on his lead chronically for those patients, and to perhaps either have a backup lead in the right ventricle or a left ventricular lead for pacing, because it ended up showing a significant increase in lead failure on follow-up. So left bundle lead, on the other hand, is a lead that instead of, if you make a line from his to the apex of the right ventricle, it will probably be a centimeter and a half to 2 centimeters down that line. And what you do is you go on the RAO view further down in that line, about centimeters to 2 centimeters. And in LAO view, you'll see that you are facing the septum. And basically, that's where you're going to be inserting that lead to try to capture the left bundle itself. And there's different kinds of left bundles and his leads, his anatomies. Some of them can be very, very easy to target. Typically, there is one that would be kind of more obvious and easily accessible for you. There are sometimes that are totally embedded in the muscle, so there is no way to have true pure capture of the left of the his bundle. And there are some that are really on top of the membranous, very bare type looking leads, and it's not very stable. So we're trying to with the his lead itself, as I showed you, you can see actually the signal. You have a little bit of an isoelectric HV interval, and you're able to capture that lead very clearly. How do you find it? You really want to go and sometimes, early on in the experience, you can always use a quadrupolar catheter and see if you can locate it that way and then insert your lead. But there are ways of doing this, and I'll gladly show you this if we have a chance tomorrow, to basically localize it directly with the sheath and the lead and be able to implant it at that time. So you're always going to have what we call non-selective and selective capture of the lead, and which means non-selective here. This is sorry. The non-selective part means on this half, first half means that you are capturing some of the myocardium in addition to the lead. So it is relatively narrow, but you don't have that isoelectric interval that basically denotes that you're really purely capturing the His bundle. This is non-selective, meaning that you're capturing some of the adjacent myocardium. And the initial thought that this was as good as well. You really get selective His when you're aiming at the His lead, in about 30% of the time. Most of the time, you'll end up with non-selective capture because of the anatomical variations that kind of I shared with you a little bit. What about left bundle? So left bundle, if you really have pure capture, you end up with a right bundle morphology because you're pacing from the left to right. You have an RSR prime type of pattern that you will be able to discern, and you have a very sharp, rapid time to peak R wave interval, which is really what you are hopefully trying to capture. And we also looked at outcomes in this and with this type of approach. This was published earlier this year, and you can see that if you compare left bundle area pacing to the traditional right ventricular pacing, you also reduce significantly mortality, heart failure hospitalizations, and biventricular upgrades in those patients. And you can see the morphology looks very attractive in the sense that it's a much narrower morphology compared to right bundle to traditional pacing, as well as you have this RRS R prime type of morphology. Sorry. So all outcomes, even including all-cause mortality. This is non-randomized. You have also several nuances to what you capture. So if you capture only muscle here, this is septal capture, you can see that what you want to look at is this time to peak R wave, which is longer than you would think or like to see. Typically, you want to see a good 60 to 70 milliseconds. You can see it immediately on the monitor if you're watching the QRS, the capture QRSs, because you will see how sharp the upward deflection is, and you can tell you're capturing the conduction system. Now, this is a diagram. Typically, the bundle branches on the left side are a lot wider. So actually, your chances of capturing it, if you just go by anatomical location, is actually a lot higher than what you would achieve by trying to select His bundle capture. So one of the attractive things about left bundle area pacing is that it's much easier to do than His bundle pacing. It also ended up being a lot more stable because it's a little bit deeper in the myocardium, in the septum, and you can truly achieve a very attractive morphology as well doing that. Now, there is another really exciting thing that you will stumble upon on occasion, not on every patient with left bundle, and that is if you truly have what we call longitudinal dissociation, meaning that the left bundle is just truly blocked in the proximal portion when you have conduction. عندك سؤال؟
لو سمحت يا شباب اقفلوا الميكروفونات، الأسئلة في الآخر.
لو عنده سؤال later
في آخر الجلسة يا شباب، وحد بيتكلم وهو فاتح الميكروفون.
You can have sometimes block proximally in the left bundle.
اللي بيقرأ الأسماء لو سمحتوا يقفل الميكروفون.
You can have capture of the distal bundle and actually correct the QRS if you pace beyond the level of block. And this is what's called longitudinal dissociation, which means there is dissociation, the bundles are kind of going parallel down the conduction system and they're dissociated, and there is block in one area of the left bundle that you can basically bypass by pacing more distal to that level of block. So that's another additional exciting thing that you will see if you look at all patients with left bundle for conduction system pacing. particularly with left bundle, and you would be very pleasantly surprised in a lot of these patients. So you want to start by mapping this bundle. You're going to use the unipolar signal. So it's a unipolar signal. You're connecting the lead mostly to the atrial port of the cables of the analyzer. You will have to run the electrogram a little bit faster and increase the amplitude, and you will be able to see his signal, the H signal in many patients very clearly and very nicely. And that's when I would encourage you to resist the temptation to really go ahead and use that, but actually look at using left bundle pacing. So going further down about a centimeter and a half or so, and try to torque that sheath as septally as possible, and try to screw in the lead as deeply as possible. The nice thing about this lead, as opposed to the other leads, is that it is a thin lead that can penetrate the septum a lot more than the other commercial ones. All companies have now delivery sheaths for left bundle and his bundle pacing. They use their commercially available 6 French leads. I kind of think and believe that this specific 3830 lead does perform better in this regard because of how thin it is, and actually I think that the sheath that comes with it is also has a little bit of an advantage. It has been also used the most, so the biggest experiences with this lead. So what I will ask you to do is I'm going to want you to look up this LOT CRT study that looked at basically here. The LOT CRT study was published in the Heart Rhythm Journal in January, where we looked at in patients with left ventricular systolic dysfunction who are basically candidates for a CRT device the traditional way with the left ventricular coronary sinus lead. And we looked at what happened if we added his lead or a left bundle lead in addition to the coronary sinus lead for pacing. So instead of pacing from the RV apex, we are pacing as it's shown on the right side. You are pacing from the left bundle area and from the left ventricular lead side, and see what happens with those patients. So what happened immediately, which is what you're going to see in the lab, is that your QRS width is going to come down dramatically. So you're going to have significant improvement in that population, with very nice narrow average going from 182 to 144 milliseconds. Even just doing left bundle area pacing by itself was better than doing this traditional CRT pacing in that regard. So that's an immediate way of looking at the outcome in those patients. The other thing that they saw is that the EF improved, quite significantly in those patients. Your diameters and measures in diastolic and systolic diameters, class association in ventricular and diastolic diameter also improved. Both systolic and diastolic diameters improved quite significantly. So that may be something to really get very excited about. This was not a non-randomized study, and there were non-consecutive patients. So we really have limited data as far as the clinical outcomes in those patients, but it really looks very promising. And I think you should start getting your hands on left bundle area pacing in particular. In a lot of patients, to begin the process so that when you really are ready for the heart failure patients, you can try to optimize that line of therapy for them. Just one particular area where I think this is a very attractive modality, particularly that you would probably have longitudinal dissociation and you probably can capture the left bundle more distally, is patients post TAVR, because that becomes an excellent target, in my opinion, for conduction system pacing. You can actually you have a marker already on X-ray with the device itself, with sitting in the aortic ring and the aortic root, and if you just go touch distal on the LAO view, you should be able to capture the left bundle very nicely in those patients. That's really all I have for you today. So questions.
Thank you very much, Dr. Ahmed. We have now 23 participants from Egyptian Fellowship Program and from Ain Shams University. كان في حد عايز يسأل يا ولاد، اتفضلوا.
دكتورة ميرفت، أنا محمد المغاوري. دكتور أحمد
دكتور مغاوري كونسلتنت الكتروفيسيولوجي من معهد القلب، وهو دلوقتي هيز رانينج مستشفى الناس، وكان قبل كده في مجد يعقوب. اتفضل يا دكتور مغاوري، عندك الدكتور احمد عثمان كله اذان صغير. اتفضل.
ازي حضرتك يا دكتور احمد؟
حضرتك منور. ازيك يا محمد، اخبارك ايه؟ الحمد لله.
حضرتك وحشنا والله. ماشي. بقول لحضرتك دكتور احمد، هو دلوقتي يعني الانيشال local experience عندنا، انا I didn't do them myself. نفس الحكايه لما كنت في لندن، كان leads turned out ان هم they fall out a lot. هل ده بيحصل برضه في الليفت باندل pacing ولا بشكل اقل؟
For the last year and a half or so, I've been doing exclusively left bundle pacing, left bundle area pacing, I should say. And it has been remarkably stable. So it's actually very, very stable in position. The thresholds don't rise as they would rise in probably 25 to 30% of patients with the his bundle pacing. So we have really abandoned the pure his bundle pacing in favor for left bundle area pacing. And the reason is very obvious. It's much more, you're implanting this lead into a much more muscular portion of the septum. It's a thick septum. And what you typically want to do is you want to have the tip of the lead quite embedded in the septum. So it's a very, very stable position, actually. And we've been very happy with the outcomes on follow-up. We will be publishing those results as well in follow-up. So that's really that took care of the problem of instability. And it's really this, the nice, it's great to have a pure his bundle or selective his bundle capture, but if this is not going to last too long for the patient, then you really are not going to be able to trust it too long. And that's really what happened. So we've moved completely to left bundle area pacing.
Okay. ممكن سؤال تاني؟ ممكن سؤال تاني؟ طيب, yes. I have a second question or a follow-up question. يعني, in your experience, how many cases do you need to run a program? يعني, there are some things that are difficult. Why, to the best of my understanding, this can takes a long a learning curve. What is a good number that you need to run your hands or to have a proctor قبل ما تقول I can do it on my own? يعني.
I think I think in your hands, Muhammad, I think you'll have a very short learning curve. How's that for an answer? No, the answer is you really, I know Muhammad from the past. I worked with him as a excellent electrophysiologist, by the way. If you don't, if some of the audience doesn't know him, but what I really think you should do is you should try and see. لا ربنا يخليك. بص, you should see it a couple of times, and I think you're going to have a little bit of trepidation early on, but you want to go ahead and break that the concern. It really is a lot simpler, and actually it's a lot easier than his bundle pacing. So left bundle area pacing is a much more amenable. It becomes the standard right ventricular pacing modality for you. It's not a very tricky procedure. It's not a very difficult procedure. I think we want to see it a couple of times with somebody, and then you should be able to put your hands on it.
ميرسي جدا، شكرا جدا، وشكرا دكتوره ميرفت. وانا يعني بشكر دكتور احمد ان هو منورنا، وبشكر دكتوره ميرفت جدا على الدعوه الكريمه ومودريتنج this. Thank you very much.
شكرا جزيلا يا مغاوري. ويا شباب اسئله ثانيه؟ صلاح انا عندي سؤال يا دكتور احمد. هو أيوة. طبعا انا عارفه اللونجيتودينال ديسوسيشن بتاع الهيز باندل، وان انت ممكن تجد مكان تكابشر منه، بس حضرتك لو بتشتغل عيان كومبليت هارت بلوك اللي بيجي لك بهارت ريت 30 و40، هل فعلا الليفت باندل بيسنج او الهيز يعني بتنفع فيهم؟ يعني الواحد شود ستارت تراينج قدام ولا ما يجربش في الناس دي من الاول كده؟
شوفي حضرتك حاجه، هو دلوقتي اللي عنده كومبليت هارت بلوك وجاي عايز بيس ميكر، محتاج بيس ميكر to rely on. If you adopt the strategy of inserting a solid left bundle area pacing in a reasonable location, you may not be capturing the true not normalizing the QRS completely, but what you will do is you will end up having a lot less heart failure endpoints, and it will clearly be far superior than having a right ventricular apical lead. So I think what I would encourage you to do is to adopt it for all pacing modalities, including heart block, especially with the left bundle area pacing, because it's actually a lot more stable than what we had before. If you have low EF and heart block, then perhaps you want to use a left bundle area pacing and a coronary sinus lead if you have the finances and the coverage for it.
Thank you. احنا عملنا ليفت باندل بيسنج ريسنتلي مع دكتور براين من ساوث افريكا، وعملنا معاه كيس باندل بيسنج من عده سنوات قبل الكوفيد ايرا، والحقيقه العيانين ماشيين كويس وفي امبروفمنت، وكان نفسنا بس الادوات ان هي تدخل مصر عشان نكمل في الاتجاه ده، يعني اللي هي الابروفال بقى، مش مجرد ادوات مع ميشن. فان شاء الله لما نكمل في السكه دي هنبقى نطمنك على مستوانا
ان شاء الله. تمام.
السلام عليكم دكتور ميرفت، ممكن سؤال؟
محمد موسى مدرس امراض القلب في طب عين شمس، وهو طالب في دبلومه الالكتروفيسيولوجي، ومن الستارز بتوع عين شمس. ان شاء الله يعني نتوقع له مستقبل باهر. اتفضل يا دكتور موسى.
شكرا لحضرتك دكتوره ميرفت، شكرا لك تعبك دكتور احمد عثمان. هل في امكانيه ان احنا نستخدم اللونج شيز بتاع السي ار تي مع تقصيره او كونفنشنال ليد كليفت باندل برانش بيسنج، ولا هيبقى الموضوع ده صعب يا دكتور احمد؟
غالبا هيبقى صعب لان الكيرفتشرز مختلفه مختلفه شويه، فانت يعني يا ريت لا you can do a lot of different things. وبعدين في شيتس كمان بتبقى deflectable، ف you can try بس it's a very nice sheet لما تشوفها وتجي لك وتبقى في ايدك. Look at the curvature, look at the deflection. There's two curvatures. There's a primary curvature and a secondary curvature عشان تخليك تقرب للهاي septal location اللي هي التارجت area. I mean, you can do a lot of different things. يعني if you want to fashion a sheath manually or use a deflectable sheath, the other ones, the answer to that, الشركات الكتيرة التانية، وبعدين أنا بستعمل كل الشركات by the way, so I don't have any يعني ما عنديش أي علاقة تجارية بأي حاجة، لكن الشركات بوستون ساينتفك والأبت والبايوترونيك عندهم sheaths. الشيث وجربتهم كلهم في الليفت باندل اريا بيسنج. دي actually is performing a lot better in my opinion. there's you can try with any sheath you want. على كل حال ده هيبقى احسن اكيد. high septal position will clearly be better than RV apical position in those patients.
تمام دكتور احمد.
لسه بقى محتاجين لسه clinical studies. We don't have a good large randomized study, but I think it's going to happen very soon. I know that there is actually ongoing studies.
تمام، شكرا لحضرتك.
اوكي، نشوفكم بكره ان شاء الله بقى لو تمكن.
خلاص ان شاء الله. شكرا جزيلا يا دكتور احمد عثمان، واحنا اسفين على بيروقراطيه النظام، لكن ان شاء الله ربنا يفرجها.
ربنا
ويمكن يبقى لنا نصيب يعني، وعشان نشوفك تاني. واهلا بيك في بلدك مصر، نورتها. وشكرا جزيلا للشباب الزماله وشباب عين شمس ومحبي الالكتروفيسيولوجي. شكرا.
تمام.
صلاح
مع السلامة.